Now we're going to take up the topic of smoking, and I think we all know that smoking, number one, is an epidemiologic risk factor for Crohn's disease. It's thought to be actually a protective factor in ulcerative colitis, again, epidemiologically speaking, for the onset of disease. So if you look at epidemiologic studies, you'll find more often that ulcerative colitis may be a disease of non-smokers or ex-smokers. And we've all had these patients who they quit smoking and then within 6 months, they have their first flare of ulcerative colitis. But in patients with Crohn's disease, there's no question that if a patient continues to smoke, they're going to have worse outcomes in every respect with regard to their Crohn's. They'll have more likely to develop perianal disease, ileal disease, which may be stricturing or penetrating more so than non-smokers. It may be an independent predictor for the need for more maintenance treatment. I think all patients need maintenance treatment, but may be more refractory to it, more biologic therapies. Smoking cessation actually may be very powerful in the treatment of a patient with Crohn's, and some studies estimate that it has the efficacy of a drug therapy in actuality. So one of the best things you can do is get a smoking patient with Crohn's to quit. So patients who smoke should be counseled. This is a strong recommendation, great evidence for it, and smoking should be avoided, and active smoking cessation programs should be encouraged. And again, we're very fortunate we have a pharmacist who actually can counsel and prescribe and do all these things with our patients to get them to quit. Now, the story is interesting in ulcerative colitis. So especially for those patients who were prior smokers, they may want to take up smoking again to control their disease. We don't recommend that at all because of the known cardiac, pulmonary, oncologic risks. The risk of smoking really greatly outweighs any benefit for patients with UC. And if you actually look into this with systematic reviews and meta-analysis, you cannot actually find significant differences with regard to colectomy rates, flare of disease, proximal extension, development of pouchitis following surgery, after J-pouch creation. These things they're trends one way or the other, but none of it is significant. So that's evidence that you can bring back to the patient. On the other hand, they do have all the same risks that any human being would have for cancer and heart disease and other things in relation to smoking. And on the right-hand side, smokers had a similar risk to non-smokers, and smoking cessation was not correlated with worse disease course in all these different aspects of corticosteroid requiring flares, thiopurine use, corticosteroid dependency, hospitalization, colectomy. So we have multiple lines of evidence suggesting that there's no reason for you to continue smoking. In fact, there's every reason to quit. So that is what we recommend. Next subject is nutrition. A very important health maintenance topic and something that all of our IBD patients will ask us about at one point or another, usually on the very first visit. They want to know, what should I eat? But apart from that question of what can I eat to treat my disease, there's another thing that we under-recognize, really, which is malnutrition. And this applies for both Crohn's disease and UC patients. The estimates are very broad because the definitions are very different in the literature, but probably somewhere between 20 and as high as 85% of patients with IBD may have malnutrition at one point or another. And of course, malnutrition has many important effects on immune function itself, muscle function. You can get sarcopenia for sure, respiratory function, and many other different things that are negative. Many poor outcomes are associated in patients with IBD who are malnourished. Risk for venous thromboembolism, non-elective surgery, increased mortality, all increased with malnourished patients, and certainly an increased risk of postoperative complications. It's not the drugs they're being treated with, it's actually the malnutrition that is more dangerous to them. They'll have longer hospital stays, decreased quality of life, and overall higher health costs. So many reasons to want to know if your patient is malnourished. It's thought that the prevalence of malnutrition is maybe higher in Crohn's disease than in ulcerative colitis. It evolves over a longer period of time. Patients with UC, if they're malnourished, it's much more likely to be in the setting of an acute flare. And ileal involvement in patients with Crohn's disease has a particular impact on nutrient absorption and you'll see protein energy and specific nutrient malabsorption or malnutrition more often in patients with Crohn's disease. In UC, you're more likely to see, of course, anemia because there's more bleeding, and severe diarrhea. When that does occur in UC, you can also see malnutrition effects. There are a number of recommendations for how to assess nutritional status in patients with IBD. I recommend that you do it at the time of diagnosis. And at our center, we do it on a routine basis. In fact, we're very lucky. One of my colleagues, Stephanie Gold, who's very interested in nutrition, set up an alert, which actually looks at the BMI and other factors, and it's a pop-up. It's very annoying, but it tells you that your patient is at risk, at least, for being malnourished, and please refer to the dietitian. So dietetic evaluation, including BMI and daily caloric intake and energy expenditure, can be done. But more importantly, there are nutritional screening tools that are now validated in IBD patients. The one at the bottom, the IBD-specific nutritional self-screening tool, is one that actually can be administered electronically to a patient and has just a few questions that are validated to predict malnutrition or risk of malnutrition. Of course, a DEXA scan is very important for a variety of patients if they're at risk for bone loss or malnutrition or malabsorption, or might have vitamin D that's insufficient. But we shouldn't forget that both macronutrient and micronutrient deficiencies are common. So things like iron, zinc, magnesium, calcium, selenium, copper, folic acid, vitamin A, B12, D, E, and K, ADEC, of course, are the fat-soluble vitamins. Those can be altered. It's better to measure those things when the patient is not in flare because inflammation affects the levels, actually. So I mentioned the IBD NST. Here are the things that go into it without going through the actual calculation of it. You can see that body mass index is one thing, asking a patient about unplanned weight loss, and if it's 5 to 10% or more of their usual weight that they've lost recently, that's a risk. Asking them if they're having a current flare of symptoms and whether they have any specific food and nutrition concerns. All these things should lead you to refer to dietary evaluation. And you can ask as well, would you like to see an IBD dietitian or dietitian if you don't have an IBD specialized one? The other thing to remember is that patients with IBD can develop ARFID, food avoidant behaviors, which restrict their eating in very specific ways that can lead to all kinds of malnutrition. So we need to be really aware of this. So what do we see about the question that patients really want to know, which is, what should I eat to stay healthy or get healthy? Well, honestly, there's not great evidence on this topic. There are insufficient studies, but that hasn't kept organizations like IOIBD from making recommendations. And generally, healthy things are healthy for patients with IBD. Vegetables and fruits. In UC, they recommend specifically omega-3 oils from fish and other foods, and decreasing highly processed foods in the diet. You see all these things on the bottom in red: maltodextrins, carrageenans, artificial sweeteners, titanium dioxide even, which is a whitener you find in all kinds of salad dressings and things. These are thought to be harmful. Saturated fats are offensive, so can trigger inflammation, and therefore you want to restrict, in particular, red meat probably, and processed meats as well. So those are the things that you can tell the patient. There's just not a lot of evidence how much good it does.